it means that you have an horizontal incisal plane that is parallel to the horizon. That's the horizontal incisal plane here, okay, is parallel to the horizon 100%. At the same time, eyes of iliac line, they are parallel to the horizon too. And at this point, commissural line also parallel to the horizon. So that is an ideal situation. And of course, in this way, you take the face bow. The arms of the face bow are completely horizontal, in horizontal plane. So everything goes well, because once you put your face bow into this part that represent the condyles of the articulator, you have the chance to see that the incisal plane is absolutely horizontal, parallel to the horizon. That is starting in this way, arrive in this way. Identical, of course. Remember, the two condyles into the articulator, these two, 1 and 2, they can maybe have a great regulation in terms of immediate Bennett, progressive Bennett, and else, also something else, like the condylar path inclination, for example. But I don't know any articulator in the market that has the chance to go up and down, up and down. They're stable in this position. So the face bow is obliged to go and to refer to these condyles. The condyle cannot move up and down. Remember that. Why remember that? Because once you have a situation like this, in which one condyle is in higher position than the other one, or even one ear is in the higher position than the other one, this could be higher than this, or this may have to higher than this. But still, you have horizontal, occlusal, and incisal plane like this. Once you have the arms of the face bow, that for this reason, for misalignment of the condyle, or some mistake on taking the face bow on the ear olives, at this point, once you have a piece that is, once the arms are collected together with a fork, is one piece altogether. Now you transfer all this into the articulator. And once you transfer all this into the articulator, you see that the incisal plane that was absolutely horizontal now is inclined on one side. Why? Because again, it was this inclination before on the head of this guy. At the same time, as I said, the two condyles here cannot put more up or more down, like is here with this face bow. So the face bow is forced to go to this reference point mechanically, so he cannot move it. And automatically, being one piece, arms and fork being one piece together, they are connected together. Of course, this kind of conjunction between the two pieces that are fixed allow you not to have the perfect incisal edge position, but it is slanted automatically. We was slanted here, it was perfect incisal plane. When you have here the situation that you should find into the articulator, automatically the incisal plane becomes slanted, become inclined. So at this point, you see that once you do that, the technician tries to help you maybe in achieving the best result, having this model that is inclined. The technician, if normally he talks to you, he explains to you that he can find some strange things, maybe you can talk together and you can solve the problem. But if you have the technician that doesn't give to you any kind of chance to talk together, at this point, he try maybe to improve the situation for you and try to elongate the teeth on the right side, as we did. You see here, now you have longer here than here, but it is now horizontal. But is really the horizontal situation that you have in the mouth? Probably not. Why? Because when you go back to the mouth of the patient, this situation that seems to be in the articulator perfectly parallel to the horizon become inclining on one side automatically. And if the technician lines up the incisal edge of any restoration parallel to the bench top, the incisal plane would be angled. That is not something that is said by Fradiani, but by Peter Dozo, that is the last neonatologist that was just passed away just unfortunately just a few months ago. So the slanted incisal plane, remember, is one of the most aesthetic unacceptable mistake. And that's for sure. Why it happens, as I said? I said because maybe one condyle is higher than the other one. But the main reason why is not that. Because we don't see the condyle if you don't do any kind of pantography or some other kind of instrumentation like that. But it's because into the meatus, acoustic meatus, the two arms can be really dislodged in a proper way, in an improper way, I could say. It's a giant movement that can be possible. Take a look. Now we are with the two olives over the face bone inside the meatus. Take a look with my hands. I can move inside, still being inside the meatus. So it can be really wrong. So your duty is that to put yourself in front of the patient, maybe using also a level like this. You see that is a level there. And check it with the horizon if you are parallel to the horizon. With what? With the two arms, right and left arms of the face bone. Remember, these arms of the face bone, they are connected by this to the fork. So it's one piece. And that's the main reason. If you start to see that this one is slanted, is taken slanted, and the fixed is slanted, then you go to the articulator, you have some angulation that maybe is not present in the real life, but is present only into the articulator. So this is again what you should do. Even though one meatus is higher than this one, anyway, the face bone, the arms of the face bone is taken parallel to the horizon. In every case, even though you have to move a little bit out, it's not a problem. As Peter Dozo said, at this point you have a correct registration, and you have again this that is parallel to the horizon, because the arms are parallel to the horizon. So in one word, if you start with that, take a look at the patient, in front of the patient, go to the front of the patient and check it. If you see the arms that are inclined, so you have to move it like this until you are parallel to the horizon. At this point, you are able to replicate into the articulator the position of the incisal edge that was already, since the beginning, parallel to the horizon. That is what you want to achieve. So, the final recommendation is align the face bone to the horizon. A slightly misrecondylar axis, if you have it, will have insignificant effect on the arch of closure. And again, that was Peter Dawson in 89, long time ago, more than 30 years ago. So let me go ahead now with the treatment plan with the walks-up and the mock-up. First of all, let me introduce to you Max. He's from Florence. He's requiring to have a kind of fixation of his teeth. But once we checked him to talk, he said, fixed teeth, maybe he needed to denture. He had no teeth underneath. No, the teeth are there. You can see it. It's a heavy Braxter, destroy all the teeth, as you could see here. And we need to restore him. Of course, yes. But we start, as always, with the position of the incisal edge. That is the starting point of every kind of prosthetic work, or removable and on fixed prosthodontics. So where you could find teeth there, you can see the tongue, you can see the lips, but not teeth. Now you can see, in bigger smile, you can see that you have the incisal edge is 5 millimeters underneath the upper lip, also the lower. So they are not visible at all, 100%. The length of the upper are 5 millimeters approximately. So that's the reason why, you see, 5 millimeters underneath. Crazy. So you need to show some part of the teeth at rest at the end of our work. You should increase at least 5 millimeters of length. At the same time, you say that this 5 millimeter length is already the length of the central incisor before the treatment. And the normal incisor length on the healthy one, on the normal one, is more than 10 millimeters, 10, 10.5, 11. So we are really missing more than half of the teeth, original teeth, on the upper and the lower. So horizontal Braxter, you see, you have shortened the teeth, you have big diastemas between the two central incisors on the lower, between lateral and cuspids on the upper. And we also would like to check what is the mandibular position. We have another lecture that we talk about all this stuff, functional stuff. But in the meanwhile, we try to remember that is the CR position that are needed to be achieved once you have to rehabilitate the case like this, because we have lost all the occlusal surface. We need to position the mandible in the right position, that is in the CR position. So before starting, in order to study the case, we need to have some functional information to be sent to our dental technician. So we take the face bow, as you could see here, the two-stone model of the initial case, plus two other kind of bite records. One is the CR record, and one other one is the protrusive record. The CR record is to mount into the articulator these two-stone models on this new position. And the protrusive record is the record that you take it between the posterior teeth when you go forward with the upper teeth, with the lower teeth, to have the edge-to-edge position. You can create some space on the back. It does allow you to regulate the continual path inclination to the real value and not giving to the technician maybe an average value of 20 degrees. But we discussed that in another lesson, another lecture. So dentist, stone models, face bow taking, CR record, protrusive record, and of course, we have some other functional informations, and with the get up that gives to you all the information about how to change the situation, as you have seen already. So, would you like to increase the video in a case like this? Do you believe that you have lost the video? It will be a long story, and again, this is a kind of lecture that will be in another lesson, another part of the course. But actually, what we could say in this case is that probably he lost the vertical dimension, but it's not said that is 100% true all the time. Why? Because many times you have a compensatory phenomena by the new opposition of the bone from the cementon of the roots. So, at the same time that you are grinding the teeth together, grinding and shortening the upper lower teeth, at the same time you could have a kind of compensation phenomena by an extrusion of the teeth. So, for the new opposition of the bone underneath. I would like to show you an example of that. In the meantime, some articles. If the eruption occurs at the same rate as tooth rate, the video could remain unchanged. But if not, the video may decrease over time. So, but it's difficult to say. Look at this, that's very useful. That's the normal situation here. The length of the teeth are normal. And A is the bone height. Now here, the teeth are much shorter. A is shorter than before. It means that you have lost, for sure, some height between the teeth, but we have gained some more bone underneath the roots of the upper and lower teeth. So it's a kind of compensation phenomena. It's never 100% probably, but it's very complicated to test it and to know exactly. But that is a kind of mechanism that can happen. Now, when you increase the video, you have to ask yourself, what about the possibility to change or not? So that are some concerns about it. What happens when you increase it? How to decide the amount of the increase? And how to test the increase? All the four questions are absolutely understandable, because you need, first of all, to know if it's possible to change what the literature said to you. Literature have changed a lot their kind of thought over years, and now mostly, I could say a big majority of articles show that it's possible to change it. This an article is a kind of systematic review that was made by Abduo in 2012, and is concluded that the video that is increased up to 5 millimeters anteriorly, just in case you need it to increase it for clinical reason, could be considered a safe and predictable procedure without consequences. If you have some signs and symptoms, they are self-limiting with a tendency to resolve within a couple of weeks. Very interesting. Very interesting. So, laboratory communication is very important. You should say, normally, when you ask dental technician what you receive from dentist, and the normal way is what is written here. Maybe you don't know Italian, but I can try to explain you. Alzare un po' la dimensione verticale. What that means? In English, increase a little bit the vertical dimension. What do you mean little bit? It's a very generic term. For me, it could be 0.5. For you, can be 1. Can be 1.5. And more than that, nobody is saying where, upper or lower. That's very important too. Why? Because many times, like me, for example, I now showing only the lower. Would you like to do half and half, upper, lower? If you create 3 mm my video, I wouldn't do it, because the lower will be even more visible. So that is a clinical test, cannot be let the technician do it itself. You have to transfer this information to the dental technician. Because you look at the patient in front of you, you have the patient in front of you. So you can decide it. Not technician for you into the articulator. It's not valid. Not good at all. Please, forget it. So you have to really give the information to dental technician. And not say un po', un peu, a little bit, chut, but being more precise. Then, dopo aver la ceratura, falli belli. Do a good job. Geez, please. Very generic information. So we have increased lower and upper. So we have to specify to dental technician the suggested video increase. And looking at the patient, you could see this was in the book, the checklist of the book, the lab chart. Vertical dimension, unchanged in this case, but you could also have increased it. Maxillary, mandibular, decreased maxillary and mandibular. So it's not something new, it's completely old stuff, but still valid. So upper, lower. So specified to the technician, also this app is the same. In the app, like in the lab chart, we have the same information at the same time. So in one word, we should send to dental technician all the information that they needed to really do a good job. And to do it, of course, we need to have more information as much as possible. First of all, determine length of the upper teeth, upper, lower. Determine the incisal position of the upper and the lower arch. That's the starting point, as I said already, of every prosthetic treatment in fixed pros and in removable or in denture. Then, third point, orientation of the occlusal point, of the occlusal plane, sorry. So incisal plane and also the posterior area, to cuspid to molar, to have the chance to see that the occlusal plane is well oriented. Then, the video determination, how much you want to increase it anyway, even though you believe that maybe not lost completely, but you need space, so it's a good reason to increase the video, as we will discuss a lot on the lesson, on the lecture on this topic. And then, occlusal posterior stability in centric relation position with a very marked contact on occlusal stamp, occlusal cusps, and actually with the chance to have light contact on anterior, as you could see here, to have an anterior guidance. So, well distributed, equal intensity, a synchronized, marked contact on posteriors, and light contact on anteriors, ready to be able to guide the anterior guidance and to form the anterior guidance with the incisal guidance and lateral guidance with the two cuspids, if you want to achieve the cuspid guidance, or cuspid and bicuspid if you want to achieve a group function. Normally that's the two occlusions that we use in fixed pros. So all these are information that the dental technician need to receive in order really to catch the case the proper way. So they are indication, recommendation for dental technician. Now, we have increased the video. Of course, you have to measure before and after you position the CR record between the two models. You increase on your pin the 3 millimeters, the three steps that you see in the pin that represent the 3 millimeters that you have increased with the wax up. And then if you don't want to increase the video in this case, you want to keep the video as it is, for example, you remove the wax, that the bite record, of course, that allow you to put these two models in CR, and then you start in the lab, dental technician is saying, in the lab start to do the occlusal adjustment until you arrive up to the end. At the same time, use also the protrusive record, as I said before. You ask the patient to go edge to edge, and then you have some space that is forming on the back that will be higher or lower depending on this. Now you have around 40 degrees. If you have 20 degrees or 25 degrees, it will be more flat. If you have 40 or 50, it will be more steepness, like here. Okay? You have the space that is formed thanks to this. Of course, the incisor guidance, the anterior guidance, plus the posterior guidance, that is that of the condyle path inclination, that is just shown here. The condyle path inclination, you see the condyle going down to this kind of path of inclination. And actually, we'll be opening the space on the posteriors, achieving the goal not to have any kind of interferences during excursive movement of the mandible. So that is our goal, in order to avoid any kind of posterior contacts during excursive movements of the anterior guidance. So the condylar guidance, that is in this case steeper, allow you to achieve easily this kind of result in this case. This is a protrusive bite record. So all this allow the technician to achieve this result. This is the wax up. Wax up is made, is completely in addition in this case. You have seen how much you have lost to structure before. So that was before, left side and right side. And now we can use this as mock-up because we have the chance to avoid any kind of grinding procedure on teeth, because the mock-up is completely over the original models. You have closed, Giancarlo closed in the proper way the holes at the space between the teeth, as you can see, also the lower arch between the two centrals. Great anatomy that was done. So remember, the wax up is the representation of your treatment plan. And of course, you put inside all the aesthetic and functional parameters, having analyzed all the aesthetic and functional parameters in the proper way. And then become a prototype for mock-up as first, and then for provisional when you have to grind the teeth to take an impression. You could see in this case we have increased the video up to 6 mm. Normally we increase up to 3.5, that's average. But in this case was really lost a lot. So to achieve the best result, we need to increase 6 mm. And at this point you can do the mock-up. Let me show you this movie. We have taken the registration about the initial increase, the initial height between the two arches, between the two central incisors, was 12 mm approximately. Then we tried this kind of silicone matrix, and then we are able to put inside this bisacrylic that is positioned in the mouth. Of course, the anatomy of this silicone mask is that of the wax up. So we are trying to stamp, to print this mock-up in place. And the wax up values was now optimized in the mouth of the patient. That is perfect. Now we do the lower arch. Again, we printed this bisacrylic in place. And again, remember that we have followed the anatomy, the new anatomy that we have achieved to the wax up. Wax up that was derived from our kind of aesthetic and functional parameters follow-up. Look, now it's perfect. Now you can change some little things. Maybe this is not allowed to use it, but it's perfect to divide perfectly the teeth between them. Look. So yeah, use a little bit. I did just very little modification before let him looking himself. And you will see now the eyes of the patient. eyes of the patient that you can feel it, some doubts. What is doing this guy? Talking about me. But I know the result was perfect, but he didn't see it. So now you see that he's closing the mouth. We just touched some little things. We are able to then finalize the case. And look then, after he saw himself on the mirror, changed completely the attitude of the patient. And that is nice to see the patient now happy. Now in talk, he can show the teeth. Finally, the final work was absolutely good. He was very happy about that. We have increased the video, remember? We have created now space between the posterior teeth. Excluding the posterior teeth, of course, you have control the functional optimization of the occlusion, upper or lower. The mock-up can stay in place for a couple of weeks, depending on the patient needs, depending on many things. But anyway, that is the result that they have achieved. Have increased the video. We didn't cover, as you could see, the recession on 21 and 22. As you could see, we have some recession. We will finalize our work on the CEJ, so making these two margins completely supragingival. Why? Because the patient, when he laugh, doesn't show at all these areas, so it's not important aesthetically. He doesn't have any risk to have problems up to now. Or you can do also this work later on after we finalize the work, if you finalize your margin on the CJ as we did. That is an option on the treatment plan. So again, increase the video. In the past, we had problems on accepting this kind of solution, but now all the authors say the same thing. You can have at most transient patient discomfort, no muscle pain, no joint pain. So many authors agree on that. We have also other articles that I will show you in the next lectures. We check the occlusion properly, stability of posterior teeth in occlusion on the functional cusps, centric cusps, and then light contact on anteriors, all that in red spots on the left side. And then all the other lateral and anterior movements of the mandible that gives to you the idea how it works, the anterior guidance, incisal guidance anteriorly, and canine guidance laterally, right and left. Now we can start to cut back and to go ahead for the final work. Once you have the chance to cut how much you believe that you need to have for you to leave for your ceramic material. You need 0.5 millimeter, 1 millimeter, 1.5, 2 millimeter, as you like it. So you cut back the same amount starting from the mock-up. Of course, having increased the video of 6 millimeter, you can find a lot of space available underneath. So you probably don't have to be aggressive at all on the teeth underneath, because they are already over-prepared by the nature, by the wear. And that is the smile of the patient that changed completely their life in terms of having the pleasure to smile finally. That was not possible before. He was saying to me that he was not laughing anymore because the teeth were not visible and because he had a reverse smile. And now she can really enjoy the new style of the teeth. We are still in the mock-up. We will have another lecture to show exactly step-by-step this case from the beginning to the end. But now, for what we have seen, what you have said, I believe that is enough to explain that is a kind of a guided aesthetic treatment, guided treatment plan, having analyzed step-by-step all the aesthetic analysis, the functional analysis, joined together the two parts, and having the chance to give all the information to dental technician in order to really optimize the final work, giving instruction, recommendation that are coming from what? From analysis of the aesthetic and the function. That is today also much easily achieved by the use of GetUp, the guided aesthetic treatment app that is really very helpful on this side. So I would like to thank you to stay with me for this lecture. I will be back to you for another lecture. Bye.